did a CAT score, which I'll demonstrate here in a second, had a score of 16. The key with the CAT score, the COPD assessment test, is it above or equal to 10, or is it below 10? It's an objective way of trying to simplify the subjectiveness of COPD, which is very difficult to quantify. The key, as Dr. Bursler mentioned, exacerbations in the last year. Are there more than 2? Is there 0, 1, 2, more than 2? Or is there 1 hospitalization? If there's 1 hospitalization, automatically jumps up to the highest severity. So, and really the provider, you get all this data entered in, the nurse coordinator oftentimes will help out, or a designated staff member. All you really have to do is go to this gold stage right here, go to the group. And we kind of gave you a little cheat sheet. Not a bad idea, just to kind of, in case you hadn't read through the gold standards, I mean, I encourage you to do so. Kind of gives you a little cheat sheet. It's about a 80-page document, maybe into four lines here, basically. So I want you to pay attention to that FEV1, the mild, moderate, severe, very severe stage. See, the second component is the CAT score. Is it below 10? Is it equal to or 10? And you'll see kind of these repetitive here as well, too, as we go from A, B, C, and D. D being the worst, A being very mild. You'll also see the exacerbations on the side here as well, too, and I'll kind of hover over one here as well, too. So in the gold group B, you have typically an FEV, 1 over 50% to 80%. In this category, a CAT score will be greater than or equal to 10, and either 0 or 1 exacerbations. Exacerbations are defined in the gold standards as any treatment that is a change for that patient. A medicine change, a prednisone burst, an antibiotic, perhaps maybe pulmonary function testing ordering. So the other thing is when you look at like category D, look at some of the criteria for that. Look at the last part of that, 1 exacerbation requiring hospitalization in the last year. So when you look at some of these stages, that's a key component. And I'll show you how we got there. And your nurse coordinator or a nurse or a designated staff member will help with this to kind of speed up some of the process. It's in the rooming tab. How many providers are in there? Probably not too many, but the nurses are in there all the time. Chronic diseases. And you ever notice some of these things right through here? So spirometry. We can enter in all the spirometry data, and we're working with IT to basically, if there's anything from a Unity Point system, get that back up here, that hopefully we're going to try to auto-sync it instead of having someone manually put in the values here. So let me pull this back up here. It's hard to see the scroll bar on this one here. There we go. So basically the importance is pre and post bronchodilator. Can't stress that enough. Has to be pre and post. Why? Reversible disease, and I'll show you that here in a minute with the gold standards. We tend to overdiagnose sometimes COPD. They're smoking, they've got poor inspiration, expiration. We label them as COPD. That's sometimes what happens, and whether it's in the clinic, in the ER, hospital, it may have been mislabeled. So the reversible cause, an asthma, is there an acute pneumonia, that perhaps was misdiagnosed. The other thing I want you to pay attention to, and I'm the EPIC champion here too, so I will kind of, EPIC provider champion, so I will kind of, you ever guys notice this row info? Gives you a little cheat sheet. See kind of when see that below the FEV and the FEC, if you kind of highlight that, it kind of gives you a little cheat sheet on there as well too, which I kind of like, we program for the providers just as a nice reminder. Kind of looking at the gold standards right there. So the mild, moderate, severe. When you come down to basically entering all the data, you come down to the CAT score. We tend to over-rely on spirometry, and it's been shown over and over again. Sometimes if you say they're in moderate spirometry, 50%. Oh, they're not going to the hospital. It's only those 30% or below. So we tend to overvalue that. We need it for the diagnosis, but it's not the most important parameter in evidence-based medicine. Symptomology, and then basically hospital visits or exacerbations. Kind of like an ACL. What's the most prominent cause of another ACL, a second ACL? This is the first one. I mean, it's pretty simple. So when you look at some of these questions, and I do this in the clinic, or you can have a nurse over the phone do this. Pretty self-explanatory. Just asking them. It takes just a couple of, a minute, 30 seconds or 60 seconds. I always say, tell me about your cough. A 0 is basically no cough. A 5 is having severe cough all the time. Give me a 0 to 5 scale, 1, 2, 3, 4. You can basically kind of click as you go through here, And you come up with a score towards the bottom, and it just basically auto-calculates and kind of gives you a little prompting questions here. You can kind of hover over it. And whether your nurse does this or you do this, I kind of like to do this when I see my COPD patients for a follow-up. This one will give a little higher score here, so 13 basically today. So coming down to exacerbations, they had one COPD admit this year. So basically I'm going to close that and save that. So now coming back into the plan, basically this can auto-update, and I can just click refresh and this should basically auto-sync. So pretty easy for a provider to kind of scan through that. So that's where I really want you to focus on that, .COPD assess. And I'll be coming around to clinics and helping with this too. I don't expect you to remember it, but so let me log out here. Let me switch. And just basically just a summary of what I've discussed today. So we'll take questions at the end. We'll kind of move on to the next stage on there. Let me kind of go back a few slides here. And I'll have Dr. Bristler come back up.
Now the interesting thing, thank you very much, President. And you look very dapper.
James Bond.
Yeah. Hello.
0.7.
0.7. Yeah, plus or minus 0.7. Know that physician time and clinic staff time is extremely valuable. So we're working right now so that when we get the catchword, the exacerbation score, and the FEV1 percentile in that formula, we are now developing so that EPI can automatically give us the group severity scoring and save some of those steps, but we're not quite there yet. I don't think it'll be more than 4 to 6 weeks before that's automated. Because anything I can take off your plate and automate, the better. We're also working on certain types of spirometry equipment, and this is being worked on right now, that the numbers from the spirometry of certain types of spirometry equipment, the ones most used in Unity Point, will automatically feed into EPIC. And you don't have to scan those in or write those in. You can they'll automatically scan into procedures. You can take the information from there. So the more we can automate, save your time, the better. So appreciative about that. I'll try to go back to where we were here. Okay, so we've gone through that. We've talked about smallness of what we're doing in that first step of just getting the ingredients so that we can do the second step of grouping. That leads us to the third step of treatments related to the grouping. Many of our COPD treatments relate to how severe the patient is by that grouping. So that's our third phase. And then you should know that this is going to be cross-continuum work. We're starting out in our ambulatory space, but we'll get to the ER and we'll get to the hospital, particularly with order sets and management of discharges and transfers. Those are very important things to make sure that we have lined up system-wide to decrease our variation and improve our quality. I'm going to ask Shelley and Milda to come up a little bit. And so we talked about the worldwide and United States population. 16 million people have COPD in the United States. Another 16 million people probably have it but don't know it. We have a large number in our, I thought there was a slide about this. If I can get back to it, I'll show you really quick. I just really want to show the grandkids again. Yeah, so it's a third leading cause of death. It's been stated. We know that about 8.4% of our population in Unity Point have COPD, 136,000 plus patients. Probably another 100,000 we don't know about yet. And we'll develop ways of getting those in the future. We know that we have about 7,000 plus hospital visits. We know that we spend a lot of money on those hospital visits. Some $16 plus million, almost 17 million. And much of that's related to COPD exacerbations. We know that 7% of people with COPD get readmitted. And we know that readmissions have longer stays and more cost. So those are things we have to think about. So we know what's happening in the country, but we know what's happening in the general world of of Unity Point. And then I want Shirley and Mill to talk a little bit about, let's drill it down to Waterloo and what this kind of work means for Waterloo. So, thank you.
Good evening. It's fun to dress up a little bit, isn't it? And it's fun to see everybody else that took the time to do that. I wanted to talk a little bit about the numbers in Waterloo to start off with. So this data, it has fluctuated just a bit here and there as analytics works to get the data, but we know we have between 1,000 and 2,000 patients in Waterloo on the list that do not have the measures met for COPD. We're able to use an application to pull those patients by clinic, by PCP, and we'll drill that down to get it as close to your personal populations as possible. We have for PFTs, we had about 41% of our patients have had one, meaning that we still have more than half of them that still need to have a PFT done. In order to encourage that effort, our PFT department at the hospital will go to 5 days a week. They do them now on Monday, Wednesday, Friday. We'll increase that to 5 days a week. CAT scores, you can see that for CAT scores and for exacerbation counts, we had very little documentation of that in the Waterloo region. And so that's what we will try to really hit hard and do that. Spirometry results, obviously they're not interconnected with Epic at this time, so the PFT will go back to your office and the results will be entered by someone there in the office. Our goal is to try to make this as seamless to the provider as they want it to be, while still making sure that you have the knowledge of where your COPD patient stands. It may not look the same in every office as far as who does the work. It'll take a multidisciplinary team in the office to manage the list and to work each component of it. And we're committed to getting that going. We've had quite a few meetings, most recently with Clinic, and I think you want to comment about that?
So as Milda said, that it's really going to vary depending on what type of support you have in your clinics, whether it be a care manager or care coordinator, and they will be working with your provider care teams on ensuring the COPD process and workflow as well, so that we can get this work accomplished this year and over the next 18 months. We met earlier with the senior administrators, so they will be reaching out to you and your teams on getting some webinars, some training scheduled. As Quentin mentioned, he's going to be coming out meeting with you as providers, so that he's coming to you so that you don't have to worry about getting a webinar and going to another location. Like everything else in the Waterloo region, I know we're going to be able to accomplish this, and no doubt we'll do it together.
You can see on the slide that there are incremental targets at 6, 12, and 18 months for the work. As we're discussing this with clinic leaders, they, their comments, as is very typical of the Waterloo region, is that they think they'll surpass all these targets. So kudos to them, and very proud of them for stepping up to that. For confirmatory testing, 55, 70, and 80% is where we want to get to diminish that patient list of those that have not had a PFT. For CAT scores, we're looking at a little simpler. It says 10, 20, and 30. We're even looking at 5, 15, and 30% for those incremental targets in some of the clinics. The list, we have decided in Waterloo that we will take the next gen list first and work through those lists in each clinic. So a typical list for a rural clinic is around 15 patients for that. A list in the Cedar Valley area, in the metropolitan area, is anywhere from 20 to 35 on that list. So we'll be working closely. The other person that'll be helping with this is Heidi Ducharme. She's the chronic disease navigator on the hospital side. She's the one that does the post-discharge phone calls to chronic disease patients, and she will begin working one of the lists herself and getting people in and getting the ball rolling. Any questions about, you'll be seeing us and hearing from us, and we'll be spending time in the clinics. Yes?
Would it make sense when the PFD is done to really start putting that data into the COPD-SS? So that you got the FE1, FEC, the date the spirometry that was done, all right there. So then when the patient is being seen, we're really just adding the number of the exacerbations they've had or if they've been hospitalized. So the clinical stuff we can put in. And that way we've got our numbers.
So right now, the way the PFT will be done in respiratory care or wherever they have it done, but we've talked to Dr. Cafaro's office, the pulmonology office, and our PFT lab. They will do it, they will send it back to the office and notify the specific person that's supposed to receive it there. They will enter the results into Epic as soon as they have the results back. Now that is up until the interface actually happens.